Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Good morning, I'm Dr. Kerry Gelb, and welcome to Wellness 1280 on Open Your Eyes Radio. Please listen as I discuss the newest information in the world of health, nutrition, and sports every Saturday morning, 6 a.m. Central Time on AM 1280 The Patriot. Also, please share your thoughts by emailing me at drkerrygelb@gmail.com. That's drkerrygelb@gmail.com. And visit my new website, wellness1280.com, where we have all guest links, Wellness 1280 info, and previous shows. Wellness is taking over the Patriot Airways for the next hour. Sit back and enjoy part 2 of my interview with Dr. William Fox. In part 1, we talked about that there's a lot of people in the United States that wear contact lenses, about 45 million of them, and the delicate balance that doctors have to go through to fit contact lenses. They have to consider safety, vision, and comfort. And Dr. Fox, who's an optometrist in North Carolina, he does a lot of volunteer work, volunteer missions between in the U.S. and overseas. He's done about 25 volunteer eye missions, providing eye care and eyewear to underserved communities. So Dr. Fox is really a great guy. He has a lot of experience in the eye care profession and optometry as being an optometric physician, helping patients. He has a special interest in fitting multifocal contact lenses, which we talked about in the first segment, but he's going to give some of the nuances in this segment about fitting multifocal contact. So Dr. Fox, thank you for joining me again today on Open Your Eyes Radio and podcast with Dr. Kerry Gelb.
Thank you, Dr. Gelb. It's always great to be with you.
So let's get into it. Let's get into some of the nuances that we didn't have time to talk about in segment 1. Tell us about some of the nuances and some of the tricks of a multifocal patient. So let me set this up. So this is a patient who typically is over 40, maybe over 42, over 45, needs different glasses for reading than they do for distance, because their close vision is starting to go, and they still want to wear contacts because there's close to 130 million people out there that are presbyopic, which loss of focusing as they get older, which is more than a third of the U.S. population as the population is aging. So let's talk more about fitting those multifocal contact lens patients, and tell us some of the tricks of the trade, Dr. Fox.
Well, and many optometrists, of course, know these things, but it is an art and a science, or I should say a science and an art. So you want to find the profile of your patient, what their motivation is for contacts, what they want to do with the contacts, and what's the physiological ability of their eye to hold and maintain a contact lens, because it has to fill it with fluid. And so moisture is such an important part. But there are other things too, and there are ways, you sort of test the flexibility of your patient as well, especially if you run into some potential problems. And I would say about half the time you have to make adjustments to get the best experience with the contact lenses you're fitting. And I have a perfect example of the last patient I actually saw in the office. And he wasn't wearing any contact lens. Well, he wore glasses occasionally for distance, but then he had to get multifocal glasses. And he said, I just can't walk in these things. I can't deal with this at all, but I can't see up close. When I take my glasses off, I'm nearsighted, I see a little better, and I have to wear them for driving. But he said, this is driving me crazy. I can't see up close, and my work involves a lot of that. So we fit him with bifocal contacts, and he loved the feel of them. He had pretty good, moisture in his eyes, and so dryness wasn't a factor. But he said, it's kind of fuzzy in the distance. And he also had astigmatism, so I had to use a more of a complex lens to fit astigmatism and a multifocal. And so I said, well, let's try to see what the problem is. And up close, he saw good, but the distance he didn't. So you take his dominant eye, and I had done his dominant eye or got it from the end of the test and the refraction from what we talked about last week. And I put a little bit of a lens over one eye to see if it's fuzzy and say, is it better when I put this lens and make it a little fuzzier in your right or your left eye? And he basically said, it's better on my right eye. But he also said it didn't seem so blurry when I put it over the left eye. So his left eye, I stayed with the bifocal contact, and the right eye, I literally took that had the more astigmatism also. I literally took the bifocal out, and because I knew he would be able to have the distance lens with both eyes open, seeing the distance a little better with his right eye than his left, but he still had the bifocal in the left to see up close. And over the years, I've found that up close, if you just have one eye, it usually works fine, unless maybe you're dealing on a computer for 12 hours or 8 hours or something. So that was just one of the little nuances that you work with. And that has to do with what I call dividing the eyes. Sometimes you have to make one eye a little better for near, one eye a little better for far, but you have to decide if they can, you have to find out if they can tolerate that. Some people cannot tolerate that at all. And so you have other things too. My father, I'll never forget, he never wore his glasses. He's nearsighted. He can see up close, but never wore his glasses in the house. And I said to him once, we're watching TV, how do you see this? You can't see this clearly. He said, no, I see pretty good. And I said, no, you don't. I said, I'm your optometrist. He put his glasses. I said, here's your glasses. Put them on. I said, now, isn't that a lot better? And he goes, yeah. And I said, wait a minute. I know it's better. But he was so used to seeing a little fuzzy in the distance that it wasn't that big a deal. He certainly used them for driving. He knew he had to see more detail. Well, those type of patients, when you learn and you ask them when and how they wear their glasses, you may know that now this patient, you can put a bifocal on both eyes, even if it's a little fuzzy in the distance, because it's not going to bother them. They're used to that. As long as they can see. And you see it all the time in LASIK surgery where they'll see 20/25 and they say, I see fantastic. I see everything. It's wonderful. So once again, the tolerances of seeing 20/20 crisp and sharp, seeing 20/20 not as sharp gives you more flexibility in what you do. And so those are just part of the many nuances and kind of what I call the art of fitting. And it's like a puzzle. You just go and when you see this, is it clear up close? It's clear distance. Can you make one eye better for near, one eye better for far? What are the tolerances of the patient? So some psychology involved even.
Sure. And, it's funny when it comes to computers, we always talk about the difficulties with computers. The blink rate goes down and it's dry, the increased dryness. But nothing has been really, in my opinion, better for multifocal contact lenses than computers, because computers are further away from the patient than reading. So that gives us a more slop in fitting multifocal contact lenses because they don't have to see as close. So the contact lenses don't have to be as strong for the reading part. What's your opinion on that?
Oh, you're so right about that. It does make a little bit more potential for dryness, but mostly because a lot of times there's strain there. If it's a strain, then your eyes are going to get drier because you don't blink as much. And when you're focused, you don't blink as much as well. There's a lot of studies that show that. The great Art Epstein, who was one of the greatest in dry eyes, did a study and proved that you don't blink as much on the computer and you need the blinking for the tears. But you're right. The greatest thing or the hardest thing about a multifocal glasses is that when you get to the computer, you have to raise your head up or raise it down. You have to get that perfect spot. With contact lenses, you don't. Through any place, up or down, you can see distance, near, and intermittent everywhere. If you look to the floor, it's not blurry when you're going down steps with contacts. When you're looking with straight ahead with your computer, if it's a desktop and it's straight ahead, you can still see up close, but then you can also see in the distance. If your computer is a laptop and it's down a little bit below and your eyes go down a little bit to see the computer, you still can see up close or intermittent. If you grab your cell phone and hold it up close, you can still see it. The beauty of the multifocal contact lens. And it's like I said, my patient the other day, he said, I just couldn't wear those glasses comfortably, and I don't think I ever will, but he said, I love these contact lenses. After I got him set up, and I had one for distance and one with a distance and a near multifocal.
So, Dr. Fox, let's talk about astigmatism. A big word. About a third of the population has astigmatism. What is it? And do we need special contact lenses for astigmatism? And do they make daily contact lenses for astigmatism?
Yeah, patients come in and say, I got the astigma. Or I say, oh, astigmatism. They say, yeah. And then they think, is that an eye disease? And it's like, no, it's just a part of your prescription in your glasses. And to simplify things, I tell patients it means you have more power go one direction than the other in your glasses. Actually, as a consistent change in power, having more power one place, another power the other, and where the power starts out is called the axis. So when you get into contacts, it's a little more complex fit to do that. But once again, it used to be a real problem keeping stability on the eye because the contact lenses can't rotate a lot. And that used to be a problem with the contacts. And we worked very hard to stabilize it. And if eyes got dry, it really would come unstable. But these days, they're so much better that even with some dryness, the eyes are a little bit dry, they seem to really hold their position. Some better than others. And of course, once again, an experienced doctor will know which do better and which do worse and know the nuances of the lenses they like to use. But yeah, that's the main thing. It's just a different power, one direction than the other. So you have to have different powers in your contacts and they don't want to rotate. You got to have them, you want them to move to get tear flow up under there, but just up and down. So yeah, but we can do that. They have them in dailies. Yes, of course they do. And they have one of the best in dailies from Cooper Vision that I use all the time. And they have them in the monthly, of course, as well, too. They even have astigmatism lenses with multifocals for those who have gotten into their 40s and they say, look, I want to keep into contacts, but I can't see up close. I'm tired of wearing reading glasses over top. Well, you don't have to do that anymore.
Yeah, I mean, it's amazing that they could put in that disc, that plastic, little piece of plastic, that they could put a correction for people's astigmatism, where they have the patient has a different prescription going one way compared to the other way on their eye. Or the way their eye is shaped, the prescription vertical is different than horizontal. And they make a little piece of plastic to match that. It's really amazing. And all four of the major manufacturers do it. And they all do it well. And, you know, they've spent millions of dollars in research and development. In the first segment, I spoke about how Cooper Vision, there was in Fortune magazine, and they reported that they spent, I think it was 21 or 22, $110 million just in research and development. And that's Cooper Vision, one of the contact lens manufacturers. That's including what Johnson & Johnson spends, or Alcon spends, or Bausch Shalom spends in getting the best possible contact lenses. And when I fit contact lenses for astigmatism, you know, patients have trouble a lot of times with glasses for astigmatism. They get their glasses, they have trouble getting used to them. They're walking, the floor seems tilted. They put these contact lenses on and they see amazing. And I got to tell you, I've been doing this a long time and I'm still amazed that they can make a contact lens that exact to help people with astigmatism. What do you think? Do you agree, disagree? What do you think about that?
Oh, I'm just totally amazed as well too. Even after all these years, I am totally amazed at how do they get that in that small piece of plastic and make it work, and then also keep it stable on the eye, even in dry eye situations. Yeah, I'm overwhelmed with it. And it's even more than that. It's not, and I tell my patients it's like having two different prescriptions, but you really, as you know, have many different prescriptions. It starts here and it's a little different here, here, there, there. And by the time you get here, it's totally different than the prescription this way if you have Axis 180. And then, of course, the Axis could be anywhere too. So no, I'm overwhelmed. And then when you add a multifocal in there, which gives you near vision, intermittent vision, you have like three different prescriptions in there, really more than three. And I'm blown away. And that it's still just like the eye itself. It's just a remarkable thing. And I'm always awed and amazed at.
Yeah, there's like thousands and thousands of combinations of prescriptions that these companies are able to make, and they go at 10 degrees and at 10 degrees increments that they're able to make these type of contact lenses give people the sight. It's really an amazing thing. And I really want to thank the contact lens manufacturers for spending the money for doing this type of work to help people, because they really help a lot of people with these contact lenses.
You know, I do too, because their research and development put a lot of money, a lot of time, a lot of effort, a lot of careers in making contact lenses better. And they have made them so much better and have really changed so many people's lives. My brother is, you know, he's in his 70s now, but he just still loves his contact lenses. And it's changed his life. And, and so it's just a remarkable thing. I've seen them manufacture lenses many a time. I've been to them, and you have too. And I still am just like, how do they do that? How do these engineers come up with such amazing things? But you're right. It's time, it's effort, it's determination. And I really appreciate the contact lens companies for what they do and the research they put into them. It gets better all the time.
Let's talk about myopia now. So tell us what myopia is. It's 42% of kids between, I think, 9 and 18 are myopic. About 42, maybe a little more percent of the population is myopic. Tell us what that is.
Well, myopia is seeing in the seeing up close, but you can't see in the distance. It's where the light rays come into the eye and focus on the retina in front of the retina. And so you're seeing a blurriness because they don't focus right on the retina itself. Light rays come into the cornea and it bends them toward the retina, and they all come into an image there. And retina is a thin tissue in the back of the eye. So that's called myopia. And yeah, it's becoming a problem. It's truly an ocular disease in nature because it's happening more and more and more. 150 years ago, 200 years ago, there weren't that many people nearsighted. Now it's about 40%, and it's increasing incredibly because it seems not to just be heredity, it's heredity plus environment. People are predisposed, and many of us, we're finding so many of us are predisposed to nearsightedness, and you put us in the right environment with a lot of computers, a lot of cell phones, near things that take our attention up close. Yes, it makes it much easier to start going into nearsightedness. And as I tell my patients, it's only a quarter of a millimeter. Your retina has to go back to get you a tremendous amount of nearsightedness. And if the brain thinks you're focusing up close is more important than your distance or your periphery vision, it's going to change things because the eye is just an extension of the brain. It's going to change things to make it easier for you to see up close. And then you get into nearsightedness.
Yeah, and as the nearsightedness increases, the risk of cataracts goes up, retinal detachment, glaucoma, and myopic macular degeneration. So there's a lot of emphasis put on us to try to prevent people from becoming nearsighted. And again, our partners at the contact lens manufacturers, the big four, Bausch & Lomb, Alcon, Cooper Vision, and Johnson & Johnson, are trying really hard to come up with contact lenses to try to prevent people from getting nearsighted. I know CooperVision has MySight, which is a soft contact lens, which could decrease the progression of nearsightedness by about 60%. And that's something that's been a tremendous discovery. If you could talk a little bit about preventing nearsightedness in kids, and when should we start preventing it, and when should kids start being examined?
Well, you're exactly right. And nearsightedness, like I said, is such a prevalent thing now and today, and especially if the parents are nearsighted, but they don't have to be nearsighted. Um, and as I tell people, you want to start right away by having your kids, do things outside. There's a study that was shown how someone that was spent 30 minutes outside has much higher chance of getting nearsightedness than someone, a child or an adult too, who spends an hour or more outside. So getting outside where you see periphery, where you're looking in the distance. Yeah, it's important to learn how to read early on. You do want to do that. We love to give our kids the computers and play the games, but limit their time. Have them do distance things. Keep them away from the TV and have it in a distance. You want your brain to think distance and periphery is just as important as up close. And that will help keep you from adapting into nearsightedness because often it's an adaptation. So so you want to start early on. But as time goes on, if you are nearsighted, then there are things, and there's getting more and more things that we're discovering and finding through research and development, often with the contact lens companies, that can help emphasize the periphery over the central, and like with MySight contact lenses, which has been a game changer, by the way, because it's so much easier to work with that. And those things have really helped us to get a handle on this and to start the process of trying to limit myopia in our population with our kids.
Yeah, I mean, you bring up a great point. There was a Sydney study, Sydney, Australia versus Singapore, and the Sydney kids were on digital devices just as much as the Singapore about, but they were 4 times more outside than the Singapore kids, and they had 3% myopia compared to the Singapore kids that had 29% myopia. We're speaking with Dr. William Fox, North Carolina optometrist. And we'll be back after the break. After the break, we'll continue our discussion on myopia and what we could do to decrease the risk. This is Dr. Kerry Gelb for Open Your Eyes Radio and Podcast.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
We're back with Dr. William Fox. This is Dr. Kerry Gelb for Open Your Eyes Radio on AM 1280, The Patriot. And we're talking about nearsightedness, people that could see near, but they can't see far, and about trying to prevent it. And what some of the causes, and it seems like one of the major causes is spending time outdoors. Kids that spend more time outdoors become less nearsighted than kids that are always indoors looking at computers. And you talked about in last segment how back in the before 1900, there's only about 3% of the population was nearsighted. Now we have about 42% of the population is nearsighted. So all the things where we live in an up close world. And another study that I think is very interesting is that in the winter months, nearsightedness develops 3 to 4 times faster than during the summer months where people tend to be outside. And another study that if people who spend 40 to 80 minutes outside reduce their risk of myopia up to 50%. And a weird thing is that prisoners are required to spend 2 hours outside, where our children aren't even spending anywhere near 2 hours outside. So, what kind of tests when patients come into your office, do you think are important to get an assessment of their nearsightedness?
Well, of course, the refraction that we do to see what if the child is nearsighted themselves. Also up close, how the focusing is up close. If children actually can have focusing problems up close. I know I was one of them. I wore a bifocal when I was in college, and it changed my life, And if they have focusing problems, it can turn into myopia or nearsighted problems. So you want to take care of those focusing problems because it helps them in school, but also it may help them keep from getting nearsighted or getting less nearsighted. But also, what they can see on the vision chart, of course, is where it starts. And if they're not seeing clear in the distance and up close, they're nearsighted. You want to look at the heredity of the family as well. Are both parents nearsighted? Well, pretty good chance they're going to be nearsighted. How is a child a huge reader and doesn't get outside much? Oh, they read so well and they love to read. Well, that's great. We want that, of course, but you still got to get them outside. You have to look them in the distance. The brain will adapt to where it thinks the most important thing is. And if it thinks it's most important up close, it basically says, well, why am I having to use this lens to pull the vision up? The brain can make you nearsighted, and then it's much easier to see up close. But now you can't see in the distance forever.
How about screen time for kids, babies as they get older? Any recommendations on that?
Screen time? Yeah, I would say, try to limit it to 2 to 3 hours. And try to break it up, say no more than, an hour at a time. I know that's hard. I have a son. I understand that. Don't let them get real close to the TV. It's probably better watching TV on the couch far away than watching it on their screen up close, especially as a young adult. And so, and nowadays I find that the kids are coming in, they're watching everything up close on their near devices. And it's like, no, you get family time and watch TV in the distance if you have to do that, but mainly take them outside. Let them have a peripheral vision they can see, because we want to focus our peripheral, and you do that outside. Get sunlight, get vitamin D. Sunlight is very helpful for your eyes. You got to have sunglasses to protect you in the high noon times, but the rays around and the light itself is very helpful. And of course, you get less nearsightedness, as you said, if you're outside. So I say, yeah, try to limit it as much as you can, because it's going to make a difference.
Yeah, and the American Academy of Pediatrics, up until age 2, they recommend no screen time. And then as they get older, between 2 and 5, maybe an hour max, according to the American Academy of Pediatrics. So I think that's something that people need to really think about. And, it's easy for us to use the computer as a babysitter for little kids. But, if the American Academy of Pediatrics is recommending against it, it may be something people might want to listen to.
Yes, I totally agree with that. I think an hour is up to 5 years old is more than enough. And no, you don't want to use it as the babysitter for sure. Get them involved in other things. And it can make a big difference, especially if as parents, both parents are nearsighted, because your odds are very, the child's probably going to become nearsighted in this day and age, but how nearsighted makes a big difference. And you made a good point that it can make a difference with the diseases of the eye. They're 2 to 5 times more likely to have a lot of our more serious diseases than someone that's high nearsighted.
Yeah, so we were talking about ways to decrease nearsight. We talked about MiSight, which is a soft contact lenses. There's Ortho-K, which are gas permeable contact lenses that are gently placed on the eye that the kids sleep in, that decrease the progression up to about 70%. What's your feeling about Ortho-K and for decreasing myopia?
I think both the MiSight and the Ortho-K are tremendous tools to help decrease myopia, and they do very well. And amazingly, children do very well putting on and taking off their hard contact lenses. I would have thought that would have been a very difficult thing, but it's not. And our director at All Docs which is our association for doctors next to Lenscrafters, She used to do it all the time, and she says, don't even worry about it. Kids can put them in and take them out much easier than you can, and much easier many times than adults. And and then you sleep in them, you take them out, and you can see clearly during the day without anything, glasses or contact lenses. So the parents are there when the devices are being used. So yeah, I love Ortho K. My site, of course, makes it easier for the general practitioner who doesn't do Ortho K, and most of us don't, to also get the same effect. And there's another option as well, too, the medical option, and that is very small amounts of atropine, which dilates the eye, but not in very small amounts. And that's a medical option as well.
Yeah, they just did a new study, and it was always a controversy. What dose of atropine should be used? Should it be 0.01? Should be 0.025? Now there was just, I think the study was in China, the Mosaic trial, and it showed that 0.05% atropine seems to be the most effective for decreasing myopia. But you're putting a drug in the eye of a child, and that you're doing it for many years. It's just not doing it once, you're doing it for many years. I personally don't use atropine as a treatment. That's just my feeling. I don't like giving kids to be on drugs chronically, even though it's a low dose. And a lot of people disagree with me, and I understand that. But this is my feeling. I'd rather go the MiSight route or the Ortho K route. And what's your feeling on, and we may disagree on this, on using atropine long-term for children?
Well, I agree with you in that it's always better not to use a drug every day in your eye, like atropine. Atropine in those low amounts is very safe, but still, you're building it up over day after day after day. And so I don't do that either. I like the other two options better. I do realize that it's been used for many years, even in higher amounts in children, and there have been very few bad effects as a result of that. So I'm not against that. I have some doctors in my group who do want to utilize that, and I'm okay with that. But I like the other options better.
And I think for people, it's important that they know the side effects if they do atropine, which is dry mouth, red skin, a rapid heart rate, that kids may be a little confused. They just have to know that blurred vision because the pupils dilated, some glare. If they are going that route, just to be aware of some of the side effects. I think.
Yeah. Yeah, you're right. You do get those side effects. What are they? Like mad as a hatter, dry as a bone, red as a beet. I always remember those. And then the kids can also get dilated pupils with glare and possibly difficulty to focus, even with that 0.05%, which is a low percent. The lower percents do better, but you're right. The studies are indicating now that 0.05% gets you the best results. But there's some children that can't handle that, so especially light-eyed children that have large pupils anyway, and many children do, are going to can have a little bit more of a difficulty with that. So a parent needs to be very aware, and a teacher too, especially with their reading and if they're having complaints of bright lights and things such as that.
It's really interesting that we talked about controlling nearsighted, and we want to do that because the more nearsighted you get, as we talked about, greater risk of glaucoma, cataracts, retinal detachment, myopia, macular degeneration. Now there are going to be glasses that are going to be coming out. So people are going to be able to, kids are going to be able to use these invisible bifocal glasses that can decrease myopia. So look for that to come. Do you have any opinion on that, Dr. Fox?
Well, it's amazing. Once again, what research and development is doing, and it's coming mostly out of our country, and I'm very proud of that. And yeah, you're right. There are going to be glasses that will help. I don't think they're going to do as good a job as the Ortho K that you sleep in at night, or the MySoft, or the other soft lenses that will be coming out. But yeah, I think it's going to help. It's going to help a lot with decreasing in parents and children who don't want to wear contact lenses, but can help with the myopia. This is a whole new area, which I'm so glad we're doing, and it's the time to do it because it's taking over the world. And using these type of research and development things and having them in glasses too makes all the sense in the world. And so I'm happy to see that.
So let's change our attention, shift our attention away from contact lenses to some more of the medical things that we do. Talk about the eye as a biomarker, and why is a complete eye exam so important rather than just a refraction?
Well, that is the one thing that I try to get over to my patients and to the general public. The eye exam is not just about seeing more clearly. And if you do see clearly, doesn't mean you don't need to see the eye doctor, because there's so many things we see in the back of the eye. Just for vision itself, you can have a hole, you can have a tear in the retina that you're not going to feel because there's no feeling in the back of the eye, no pressure. If you have glaucoma, there's pressure put on your optic nerve, you're not going to feel that. And the last thing that will happen is that you'll lose vision. But at the same time, it has so many biomarkers for determining or telling you the health of your body as well. There's 300 systemic diseases, bodily diseases, that you can see at times through the eye. We often are the first to diagnose diabetes, even though it's probably been there for a while. People don't always feel that bad with it, or they think maybe I'm just getting older, and we will be the ones that see it. And because you can see the vessels in the back of the eye, and if the vessel and what's happening with the small vessels in the back of the eye is probably what's happening or going to happen with the larger vessels in the rest of the body.
Yeah, I mean, the eye is a tremendous biomarker. We could see early signs of diabetes now because the cameras we use, we're seeing the retina, or these capillaries at 8 microns. In the old days, when you and me finished school, we were using an ophthalmoscope. We were seeing about 150 microns. And at that time, by the time we started seeing hemorrhages and changes from diabetes, typically the patient would know they had diabetes. But it's flipped now that we can see at 8 microns. Now, many times, and many times, it's the eye doctor who's the first one, the primary care eye doctor, the first one to diagnose that you may have diabetes. Because if there's a hemorrhage in your eye, it could be diabetes, but it could be many other causes.
You're so right about that. And as we're seeing better and in different layers of the retina has 10 layers, and as you go down, it's harder to see clear. But in certain instruments coming out, you're going to see clearer and clearer. And as you know, you yourself did an incredible study at the Academy of Ophthalmology that was presented in 2016, and I was a participant in that, to determine that you could tell up to 5 to maybe even 10 years someone who had an 80% chance of getting diabetes through the eye. So this technology and this knowledge is just at the beginning point, and there's so many other things. And I know you're a pioneer, and I appreciate and thank you for that in this area to help work with systemic diseases seen through the eye. And it's going to be a huge change in our profession and in the medical treatment alone, with work that you and others have done in this area.
Yeah, I mean, we could see the earliest signs of ED in the eye, not the ED that everybody's thinking about, but endothelial dysfunction that can lead to the other type of ED. Because in the eye, people that have endothelial dysfunction, one of the earliest signs of blood vessel disease, the endothelium is responsible for producing nitric oxide and other factors to keep the body safe. If that is starting to become damaged, somebody's at greater risk for heart disease or stroke. And if somebody has endothelial dysfunction, if they have some of the signs in the eye are microaneurysms, hemorrhages, exudates, that means that they're at risk for diabetes, they're at risk for atherosclerosis, they're at risk for cardiovascular disease. And we could see that in the eye.
You're so right. And, there were times when you would look at the eye and you'd see a little hemorrhage. You'd say, well, let's see if it's still there when it comes back. And you test for diabetes and it's not there. And we would say, well, I guess it's nothing. But now we're realizing and understanding. And once again, I thank you, Dr. Gale, because part of it's your work, that this could be endothelial dysfunction, which can have huge problems, cause huge problems systemically with the body, with the heart, with the vessels. And we are in a situation where we can catch it early. And as time goes on, we'll do so more and more. as a participant in your study starting in 2012, I actually found that I was the one that had the microaneurysm in the fifth level that you discovered. And I was headed for diabetes. And I made lifestyle changes and things that you recommended. And to this date, I'm doing great, still don't have diabetes, and I'm healthier than I was in 2012, a lot healthier. And I thought I'd have to retire at 65. I'm 70, and I can continue to go on probably indefinitely.
We see so many different things in the eyes. We sometimes see the vessels we call it vessel tortuosity, where all of a sudden the vessels get very curly, like curlicue inside the eye. And that can be associated with kidney dysfunction. Blood pressure changes. We start to see that the blood vessels start to change inside the eye, where the veins inside the eye will start to look like there's beating of the veins or looping of the veins, alteration. Different types of hemorrhages could be different types of problems. So we see hemorrhages in the eye. Most of the time, it's probably diabetes, but it could be other things that could cause the problem. I had an interesting patient who she had a lot of hemorrhage in her eye, and she had a vein occlusion, and we sent her out. And what she had very high platelets. So it could be a sign of many things. So that's why when we see these type of issues in the eye, the patient has to be worked up, and they need extensive labs to find out what the cause is. And there's over 1,000 labs. So if the doctor does the wrong lab, they might say you're okay, but they might have done the wrong lab.
You are so right about that. And so many times, what we used to say, well, they have tortuosity of the vessels, and thought no more of it. But now all this new technology and knowledge is coming out that says, no, that means something or could mean something. And so we need to work with that, and working with the general medical field, medical doctors. It's getting to the point where it's almost imperative to have your eyes examined. You don't just want to go. You want to see your general medical physician, of course, every year, but you also want to see your optometrist every year as well. And this is a whole new horizon with the technology and the knowledge of us having a whole different perspective as eye doctors, not just for the eyes and the vision, but also for the entire health of the body and the longevity and the health, and discovering potential problems percolating within the body that can cause a lot of damage. And it's whole new research coming out, and it's going to present a whole new day in the profession of optometry and ophthalmology. And I'm very excited about it. And I don't want to toot your horn too much, but you're right in the midst of all that. And with testing for yourself, presenting optometrists with testing for endothelial dysfunction, the work that you've done up in New Jersey. So thank you for that.
I appreciate the kind words, Dr. Fox. Diabetes being the leading cause of blindness under the age of 55, over the 55 being macular degeneration. And the technology is really driving this. Our technology partners, just like our partners in the contact lens fields, which are driving technology and making better contact lenses, they're making better technology for us to use to be able to help patients to discover disease much sooner.
Yes, it's so exciting. I mean, the instruments are going to be coming out that we can get down to that, as you described it, the fifth layer where so much of the action is. We don't see that quite as well as we want to now. We're getting down to 8 microns, but to see it clearly in the fifth level is where we're going to discover so many amazing things. And instrumentation is going to be coming out pretty soon that will give us clear vision down to that area. And I think that's going to be a game changer, where once again, a general physician is going to say, okay, now you need to go see your eye physician, just like they do now if you have diabetes, but they're going to be saying it for everybody, because there's so many things that we're going to be able to see that others won't be able to see. And once again, we're talking the body systemically, not just the eyes.
Yeah, I mean, it's 37 million. I have 37 million people with diabetes in the United States. There's 100 million people with pre-diabetes or diabetes. So now you're going to go to your optometrist. They're going to be able to see these things so early. They're going to be talking to you about diet and exercise and lifestyle changes so you don't get these diseases, because we're the first ones to see that you're at risk of it. So I want to thank Dr. Fox for joining us today on Open Your Eyes podcast and radio. And Dr. Fox, if people want to find out more about you, how can they do that?
Well, go to our website, Fox Eye Care Group. We're in Greensboro, Raleigh, Goldsboro, and Winston-Salem. And there's a lot of doctors, great doctors. You'll enjoy them very much. And we thank you, and thank you, Dr. Gelf. And I'm very excited about the horizon of optometry. What an amazing profession this is. And I think we're going to really be able to help out the whole medical community.
Thank you, Dr. Fox. And to the audience, we'll see you next week. This is Dr. Kerry Gelf.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.